Innovation, Yorkshire and Humber. My name's Jane Skinner. I'm a retired cardiologist and I'm now working with Health Innovation in North East North Cumbria around the strategic advisor for cardiovascular disease. Can you pop up the next slide, please? Just a couple of housekeeping points before we get into the talks. The event's being recorded and both the recording and the slides will be shared after the event in the next few days. If you do have any questions, and you may well have quite a lot, then please put those into the chat. We will try and address the questions at the end of the speakers' presentations, but if there isn't time, then we can either follow up with that as part of the chat or afterwards. We're very keen that the sessions meet the requirements of you, so do please take a few minutes to complete the brief questionnaire for the evaluation, because we really want to see your feedback, both good and bad, because that helps inform future events. Now, if Ron has joined us, I will now, yes, he has, I think. Then I'm going to hand over to Rani Khatib. We've got two excellent speakers today. Rani is our first one and Helena Gregory is our second. Rani is a visiting associate professor and is a consultant pharmacist in cardiology and cardiovascular research. He belongs to the Leeds Institute of Cardiovascular and Metabolic Medicine and works at Leeds Teaching Hospitals NHS Trust, where he leads on the cardiology medicines and risk optimization agenda and has done a huge amount of work with regards to statin adherence, which is clearly a big issue for us all. So very warm welcome to Rani, who I think has his own slides and is going to share the screen.
Great. Excellent. Let's have a look. Here we go. See my screen okay?
Yes.
Yes, brilliant. Right, thanks everybody. Thanks for the opportunity to share with you some reflections, statin adherence, as stated in the objectives. We're going to start by talking about adherence to treatments for cardiovascular disease in general, but we're going to focus on statins. And then later on, I'm going to hand over to Helena to actually cover an important aspect which is related to personalized care and how it fits into the whole agenda of adherence. So to start with, I thought just give you a bit of an idea what I'm hoping to cover. And basically, I'm hoping that we will look at an overview of adherence to treatments of cardiovascular disease generally. And we will then talk about what is the definition, how is it impacting cardiovascular disease in general, and statins in specific, what can we do about it, how can we address it in clinical practice. That's the objectives. So the good news is that prevention works. This is data from 2012, and I'm sure if we revisit it for nowadays, it will be even better. But it looks to show that 50% of reductions are seen in coronary heart disease mortality due to changes in risk factors. So optimizing risk factors is quite important, and 40% has improved treatment. So both have contributed to huge reductions in the burden of coronary heart disease mortality overall, and that's across the globe in different countries. The issue is with all these interventions, whether it is lifestyle modifications, whether it's medicines, is that if we don't do it, it's not going to give us that benefit. So as the term goes, that drugs don't work in patients who don't take them, and we can do the most brilliant review of a patient and prescribe those medicines, but if they are not being taken, they're not going to work, and therefore we're not going to see these benefits that we're talking about in terms of mortality benefit and cardiovascular benefit. The same applies for lifestyle modifications. The same applies even for adhering to a recommendation made by physiotherapists, etc. So there's a need to act on what has been recommended or prescribed. This has serious consequences. This is an interesting study where it's called the MI-free study, where in this study they were trying to see how adherence or non-adherence to second prevention medicines makes a difference in terms of outcomes. And they followed those patients post-MI. They made all the medicines free, and despite the medicines being completely free, patients were still non-adherent. But what's interesting, if they were to look at the major vascular events or revascularization after the first event, you can see here on the right, you've got the levels of adherence to various secondary prevention medicines and how it correlates with the cumulative incidence. So, for example, when patients were fully adherent, that's the red color, for the ACE inhibitors, beta blockers, statins, they did much better compared to those who are non-adherent or even partially adherent. And we know that from other studies, like there is a huge amount of studies in literature talking about how non-adherent secondary prevention medicines is associated with up to 40% relative increase in risk of cardiac hospitalization and up to 80% relative increase in mortality. This is an interesting meta-analysis which looked at the prevalence of cardiovascular disease and non-adherence and looking at the consequences of it. And this is fascinating because this study basically reports similar non-adherence levels to cardiovascular medicines in general and to statins to be in the region of about 40%, similar to what we know in the literature. But what is interesting is that it seems to attribute that the burden of cardiovascular events in Europe, about 10% of it, 9%, may be attributed to poor adherence to vascular medications alone. So non-adherence is seen as a major contributor to cardiovascular events when we are prescribing cardiovascular medicines in general, and of course more so for statins, I'll explain in a second. So this is very important because the paper concludes that ensuring that people adhere to what we know of medicines is likely to confer significant improvement in reduction in cardiovascular events by just adhering to therapies that we know. Hence why we are emphasizing the importance of examining that. Now, this is an interesting study as well, which looks at not achieving lipid targets. We know that lipid targets of less than 1.8, and we know that non-adherence to statins is quite a challenge. We know that it drops in the first year and even more in the second year. And I'll show you from real-world data that we've done here in West Yorkshire, where the levels of non-adherence to statins seems to drop in the first year and drop more in the second year, then plateaus, if you like, but there's always a risk. But this study is showing basically for every 10% decrease in adherence to statins is associated with 7% increase in risk of all-cause mortality and 6% increase in cardiovascular mortality. So non-adherence is quite significant, important to be addressed because it has a burden on overall cardiovascular events. That's not just to statins only, all medicines, but to statin specific. We've got a very good opportunity because we know that adhering to statins reduces the risk of, for every 1 millimole reduction in LDL cholesterol, you get a 22% reduction in your cardiovascular events. And that is quite significant. And the opposite is true in terms of just being prescribed statin can give you benefit, but every 10% decrease in adherence to statins going to give you 7% increase in all-cause mortality and 6% increase in cardiovascular mortality. Hence why the issue is quite important. So the question that begs itself, what is adherence? Because we historically used to call it compliance. We stopped using the word compliance because it sounded very paternalistic and it sounded very judgmental to patients, because as if we're asking them to comply with what they were told. And we moved away to try and use the word adherence because it kind of presumes an agreement that the patient is agreeing or the person is agreeing to the agreed plan with the healthcare professional. So there's an expectation of a shared decision-making approach. There is an expectation of patient involvement. There is an expectation of a two-way conversation that happened where the patients have agreed on something with the healthcare professional or the person has agreed with the healthcare professional, because they may not always be patients. and they therefore are planning to adhere to what was agreed, rather than it being kind of imposed on them. Of course, not adhering, as I've shown earlier on, has been associated with poor health outcomes, low quality of life, increased demand on the healthcare system, waste of medicines, and significant economic consequences. NICE, in its guidance, 2009 came out. It kind of emphasizes the importance of understanding the causes of adherence, because every patient has got a different story, and we need to personalize our intervention to patient needs. It should not be seen as a patient problem, rather it's a limitation, and patients should be helped to actually and supported in order to get the best out of what we're recommending. It's complex, it's multifactorial, and the best way to address it is to make it personalized. You know, there's a lot of kind of research around what are the different barriers to medication adherence, including statins. The best of them, probably the World Health Organization, where it tries to kind of break it down to 5 domains, talking about the social economic factors, the health system factors, the condition-related factors, patient-related factors, and therapy-related factors. We need to be pragmatic in the sense that what can we do in clinical practice? And this is something that we embarked on in our research, trying to identify what things we can modify in our clinical practice to make a difference. So with the first thing we've done, we conducted this study. We've asked 500 patients with coronary artery disease across West Yorkshire. We asked them a simple question. We said, do you take your secondary prevention medicines or not? And nearly 45% of them told us they don't take at least one of their secondary prevention medicines. Then we asked them why and which one you don't adhere to. And it was interesting. They gave us very good reasons. Some of them, the majority of them, said that they forgetfulness is the biggest reason, but some said that they worry that it's going to cause them more harm than good. Others said that they feel really hassled and it's quite a burden in their life. Others said that they feel worse when they take their medicines. And others felt that they're not really convinced, and you can see the percentages there. What is interesting, the adherence or non-adherence behavior was not all or none. It was selective. So patients would select which medicines they wouldn't adhere to for a variety of reasons. And statins were the biggest contributor to non-adherence. So statins were the most non-adhered to secondary prevention medicines. So we wanted to untangle it, and this is something we wanted to do something about in clinical practice. We've already discussed the reasons that people gave us, but we wanted to translate that into how can we help the patient. Some of these reasons, as we listing there, were around forgetfulness, but some of them were related to beliefs and understandings. So this model, which is called the Beliefs About Medicines questionnaire, in this model, the patient basically told us that they're not believing that they are convinced with the benefit they're getting from these secondary prevention medicines as one reason. Another one is that people felt concerned about their medicines. So the beliefs about medicines are quite important to explore with the patient, because as you can imagine, a patient who's got really, really high concern about their medicines, they're not going to take the medicine simply because we put it in a dosette box, or if we change the medicine, say from atorvastatin to rosuvastatin. So it's quite important to understand and personalize whatever intervention we're going to contribute in order to improve adherence, to understand what is the underlying cause. Is it simple forgetfulness, or is it that the patient has got really serious concerns and we need to alleviate those concerns? But sometimes it's practicalities. So some patients told us that they're having a lot of problems with their repeat prescription. Others told us that they can't swallow their tablets. Others told us that they can't open the blister packs. So there are elements which are non-intentional, if you like, but there are something wrong sometimes in the system that are contributing to non-adherence behavior. So sometimes the patient forgets to take the medicine because it's taken at night, such as the statin, but sometimes it's because their repeat prescription is not straightforward, or sometimes because the atorvastatin is quite chunky and they can't swallow it. All these need to be explored. And when we do logistic regression, looking at the biggest drivers of non-adherence, you find that concerns about medicines, secondary prevention medicines and statins in the context of statins were the biggest reason for actually causing non-adherence. And that's why I always say, if you want to improve adherence to medicines, the first thing to look for each patient, what exactly the barriers that they have that leading them to become non-adherent. And then you need to formulate something personalized for the patient to improve their adherence. But what we did, we asked the patients, do you have any other comments? And this is the 500 patients. What is interesting is that the non-adherent patient had more to say than adherent patients. And nearly 50% of patients, which means 250 patients, commented. What we did, we just like, let's actually analyze the comments of the patient. And this is what we got. This is the mind map of all the comments that the patient gave us by why they don't take the secondary prevention medicines. And it was huge and mind-boggling reasons. And this is where the whole thing about personalizing the intervention was needed. These are the themes that we found, like patients have concerns, sometimes concerns about specific medicines, sometimes concerns about medicines per se, side effects, people talk about alternative therapies. But then what we came to realize, in order for us to address non-adherence, everyone is actually seem to be stuck somewhere in this diagram. So somebody who's identified this as a reason for non-adherence, somebody else was identified here, somebody's here, not one size fits all is not going to work. So in order for us to improve patient adherence, basically what we need to do is to actually try and reach out to the patient, identify what their specific issues are, work for them in order to tackle the barriers and the issues that they have in order to improve their adherence. I'll just give you an example. As you can see here, for example, around statins, patient talked about media and how much media is impacting them of not taking their statins because of what they read. Patient told us about side effects. People told us about forgetting and changing regimens because it's not fitting their daily routine. And the idea behind this kind of mind map was clear that every patient is got a different story, and we need to work with this patient. And some people don't seem to have a statin specific reason. It was like more of a drugs per se reason that we need to work with them on. And thus brings us to the whole concept of meds optimization. And in most cases, when we talk about meds optimization, people think it's about up titration. It isn't. It is meant to be a person-centered approach in order to work with the patient and give them better access to evidence-based therapies and ensure the safety, of course, of them using those evidence-based medicines. And we're looking for the best outcomes. It's very interesting that when you look at the first principle of medicines optimization, apart from it being patient-centered, is that you need to understand the patient experience. That means you need to listen to the patient. You need to know what their issue is. And that's what all tackling non-adherence is about. For that reason, we developed a tool, which is we published, is available out there, is called the MyMeds. The MyMeds tool is basically the my experience of taking medicines. And the idea behind it is to explore the patient's different elements that could be contributing to non-adherence. And it worked really, really well. And we've used it in clinical practice, and it helps us hugely to identify what the issues that the patient seems to be having in relation to statins. And what is interesting is that we give them the chance to flag which medicine they have an issue with, and then we ask them to tell us what the issue with that medicine that they would like to raise with us. So, for example, tell us, do they understand what this medicine is for? Do they have any concern? And if they have any concern, what is the concern? And then after that, you know, do they forget to take the medicines? Do they actually have any practicality problems? Do they have any question they want to have? And and the MyMeds work really, really well that we've actually embedded it into our clinic. So this is our post-MI clinic, and every patient before they come to see us in clinic, clinic, they complete the MyMeds questionnaire, they bring it along to the clinic, and in the clinic, in addition to doing, you know, the general kind of secondary prevention optimization, we actually start by looking at the MyMeds findings. And by doing the MyMeds findings, then we alleviate the concerns and the issue that the patient has, and that addresses it. And this is the outcome of the impact of our clinic on non-adherence. You can see for statins, it was reported at 3 months to be around 20%, but when we use our MyMeds and we actually have worked with the patient to address their concerns, it dropped massively, dropped by about 70%. That's the relative reduction of non-adherence was massive. And that was quite informing and quite practical to do in our clinical practice. We've extended this work, and we've been working with my colleague and others. We've created something called the My Experience of Taking Statins Medicines, and this is a tool based on the MyMeds, which is copyrighted but free for use. But it added some new sections in order to try and understand what could be the contributing factors to statin non-adherence. This is real-world data from leads that we've captured. These are the different sections, similar to what MyMeds highlighting: understanding satisfaction with their statin, concerns, practicalities, fitting into daily routine, their experience with the consultation, any other information missing. And what is interesting, and we based our assessment first of non-adherence on what we call the MPR, which looks at the medicines possession ratio, which is basically looking at, does the patient order their repeat prescriptions enough? And it was interesting. This was data kind of spanning not just 1 or 2 years, but spanned over a very long time. And it was clear and evident that in the first couple of years, this is where most interventions are needed in order to ensure persistence later on with statins better. It is as if in the first year or two, there's a lot of fluctuation in adherence, and it's kind of the highest level of non-adherence, and it gets better later on. So practically, if we want to improve adherence to statins, probably we need to invest a little bit more in the first couple of years in deploying the MyMeds questionnaire to identify what difficulties and barriers patients have, and then channeling intervention to support the patients with that. These are some of the findings. For example, 10%, about 11% of patients talk about forgetfulness when they travel. About nearly 30% of patients talk about that statins not appropriate for them. They were not convinced, basically, it was actually the thing for them. 20% didn't think that they remember enough to take it. You can see here nearly 40%, they don't feel safer in terms of cardiovascular disease since starting in statins. So you can see how every patient's got different issues. When they ask them about the consultation experience, you can see that the non-adherent patient were less satisfied with the consultation experience and also with the information that were provided. And when we looked about what issues, for example, they were looking for, as you can see here, that they didn't feel that they were informed about all the options. They didn't feel that they were, or about 35% of patients did not feel that it was their decision to start the statins. They felt like they were not involved in that decision, as if it was imposed on them. And this is how they feel. We don't say that this is what probably happened in the consultation, but that's what seems to be an issue for them. And of course, other elements. I don't want to dwell all into them, but kind of how much information they received in terms of the side effects to expect, in terms of how statins work, in terms of what to do if you develop side effects, etc. There's loads of interventions. We're currently doing a literature review around that, and my colleague Emma is submitting this paper for publication, but this is a snapshot for that paper that she's writing, looking at what successful intervention seems to work when it comes to statin adherence. Modification of regimen is definitely a big thing. We see it in our lipid clinic. It's supporting patients in behavioral issues about counseling, addressing beliefs, providing them the right information. Combination therapy is important, of course, into that, which we can dwell into in the statin intolerance aspect, etc. So just to conclude, before I hand over to my colleague, so addressing non-adherence to medications in secondary prevention and in statin specific, first of all, we know that a patient don't volunteer this information, you need to ask about it. So the system needs to be in a position to ask about it. And that's what NICE has said. Ask about non-adherence behavior, but you need to know how to do it as well. So we ought to ask about it, not just when we review a patient, but in pharmacy, when we do our annual reviews. We need to take every opportunity the same way we check the accuracy of the dose prescribed. We should check how the adherence is doing, but it needs to be done in a non-judgmental way, talking more about the experience of the patient. We need to deploy some tools to work with the patient to share their experience, identify any barriers so that we can tailor any intervention to their needs. And that should hopefully work better in the whole system. So to conclude, medicine's adherence behavior is variable. It is not all or none. It is selective. Factors and reasons are many. They don't impact patients in the same way. We need to identify them and personalize them to patient needs in order to deliver something that supports the patient in the best form. And I think that will fit in nicely for what Helen is going to cover next. Thank you so much.
Thank you, Ronnie. That was excellent. There aren't any questions come through on the chat. I think that probably reflects that everybody's actually been transfixed by the slides and the information you're delivering. So I think some questions may come up in due course, and in which case, you may be able to respond at the time, or we'll take them at the end if we have time for that. Helena is now going to talk to us. She's one of the pharmacy and medicines leads in North East North Cumbria. And she lives and works in North Cumbria and has a background in community pharmacy and general practice. As part of her role in the ICB, she's the medicines and pharmacy lead for personalised care. So I'll hand over to her. Welcome, Helena.
Thank you so much, Jane, and everyone. I'm hoping my slides have appeared okay for you.
Yes, they're there. Thank you.
Excellent, thank you. So many of you who do these digital presentations will be familiar with Slido. We'll be using that throughout just to capture and share a few of your ideas anonymously into the room. So if I could ask you either on the device that you're on to go to slido.com and put the number in, or to use your phone and point the camera at the QR code, and that will lead you on there. So we're going to start off just by capturing a few ideas around personalised care. We'll go through personalised care and then we'll go on to how it applies to lipids and some of the tools that you can use in practice, going through some of the points that Rani covered in the first half. We will be using the Slido right to the end, so do keep it on your device or your mobile phone as we go. So my first question to you is actually to take you away from statins for a moment. So if you could pull yourself away from the statin idea, sit back in your chair and think about yourself as an individual and what is important to you as a person. So we're going to do a bit of a word cloud here. So everything that you put into the Slido is anonymous. So if you would like to join and start telling us what is important to you as a person. You can write what other people have written. So if you see something come up on the screen that you really connect with, quite a few people have said health, families coming through, being happy and fulfilled. If you agree with that, type it in, and as you can see, it will come up even bigger. If you want to add more than one, you can add more than one, again, if you see something. So we'll just give that another 10 seconds to finish typing the word that you're putting in. There we go. So family has come up really strongly there. Health, happiness, healthy, respect, fulfillment. Do you know what didn't come up? None of you wrote statins. I'm shocked. I'm actually not. Every time we do this, these are exactly the same things. So I've sat in 2 other rooms of people like you who've done this, and exactly the same things come through as the things that are deeply important to you as a person are important to every other healthcare professional and member of healthcare staff in exactly the same way. And actually, they're not the things that we might go in talking about. So our patients who are like us probably feel the same. The things that are important to them are their family, their health, their happiness as well. So thinking about statins and reflecting on the words that you came up with from the movies, in Encanto, we do not talk about Bruno. In Fight Club, we do not talk about Fight Club. So I'm going to add a third one. You can write a movie about this later. We don't start the conversation with the statin if we want to get the most out of that person and what they actually are here to talk about and think about and what's important to them. But equally, what we do want to get out of that conversation is that time that they're on their own. So there are 8,759 hours that someone spends on their own in a year. And if we're lucky, an hour with you. We want them to keep their heart healthy, to be able to work with their family, to live, to enjoy their life and all of the things that they've talked about through that 1 hour. And that's the approach that we're going to go through today, working around personalised care, which is one of the major changes in the NHS that's taking place and was in the plan for long-term conditions released recently. So the NHS is aiming to roll this out to as many people as possible, 5 million within the next decade. And there are different pillars to support that. Shared decision making around choice, supported self-management, health coaching, social prescribing, support with planning, personal health budgets. I'm not going to touch as much on that last one, but the previous 5 is the basic support for everybody that we can give through our work. So what is personalised care and what does it look like in practice? It's where people have more choice and control over how their care is planned and delivered, and it's based on what matters to them and their individual needs, as opposed to what's the matter with you. We're moving away from that. So why should we implement personalised care? It's back to your Slido, folks, just to have a think about this. And I'm going to ask you a question now as to why we would implement personalised care within the NHS. You've got 5 options that are in front of you. Saves the NHS money, patients want it, reduces premature deaths, or legal duties. Which one do you think it is? Have a vote. Okay. So the folks who put all of the above, the vast majority, well done, you are right. It is all of these. So it's estimated that through personalised care, we could save £4 billion to the NHS per year. In the GP practice survey for the North East North Cumbria, 40% of people wanted more say in their treatments. You might have seen recently in the media around social relationships and mortality risk, that this is actually now an international concern from the World Health Organization. It's a legal duty that actually goes right back to the NHS Act of 2006, the Health and Social Care Act 2012, more recently in 2022, and the Montgomery versus Lanarkshire case. So there are lots of different reasons that we need to do this. Just a reminder, keep your Slido open because it will come up again later on. Let's just flick back to the presentation. There we go. So we'll talk through one of the management journeys today around an initial chat after a health check, but people will go on a journey that will change throughout their life. So it's not a one-off event. It's a sequence of individual mingling events as we go through life. Our circumstances will change, our health may decline, our risk factors may change, we might have a cardiovascular event, and there'll be lots of different things to explore as we go through, but the language and very much of that is going to be the same. Your time in practice is really valuable. So actually, it might be yourself that's having this conversation and being aware of the colleagues who are around you as well to support. We'll have a look through the journey of Jamal, who's in his late 30s. He's had a blood test for his thyroid. The practice helpfully through in a wider suite of tests, and it came back with his cholesterol high. So we'll have a look at the discussion with Jamal. So first, we're establishing Jamal's understanding. We're starting with the hello, my name's Helena, I'm your pharmacist today, and then going on to the conversation about his tests. What is his understanding of it? So you know he's being called in for a purpose, and your practice manager has told you that you need to sort your quaff out for your statins because we'd like you to have a look at that. Thank you very much. So there's an agenda there for you to fulfill, and you know, because you've done your reading, that getting him on that statin is the outcome that you would like. The outcome that Jamal would like, as you've seen before, is to be happy and healthy. So how do you work together to find that joint agenda? So this is an opportunity to keep the conversation open and to actually say, this is what I'm telling you. How does it land with you? And just leaving that open. That's not going to work for everyone. Some people might need to narrow that down a little bit, but by narrowing it down too quickly, we can often miss out on that valuable information. So knowing your reason for inviting them in, but in the context of that person. Some people might call it the golden minute, the chance to pick up whether this was expected or not. He might actually be thinking, in your 30s, starting to get a little bit older now, starting to think about my health. He might have had family history, for example, that again, he expects it and worries about it. You can also pick up on his health literacy. So he might not have a clue about what his cholesterol means. But you told me to come in as my cholesterol is high. You can then go in with your management plan. Okay, we can give you a statin. We can bring that down. Absolutely fantastic. You might want to know what he knows about cholesterol to be able to start the conversation off. Which ones will open up the discussion to get that information that will be useful to form that management plan and picking up on things to use later on. So this one, I'm sure many of you will be familiar with the Q-risk calculator. This is the Q-risk 3, which can be used as a tool with Jamal for the shared decision making. So you can show his risk factors within that. So having put in his BMI, for example, his height and weight, putting in his smoking, diabetes status, his ethnicity, and thinking there are some things actually you can't change. Now, Jamal's Pakistani, we can't change that. We can't change some of what he's got. We can't change his family history, but there are some things that he might be able to change, and actually picking up on that and having some of the conversations and actually demonstrating them within the tool. So I'll show you that in a moment, could make a difference to him and thinking about where he is. So, for example, if he lost weight or stopped smoking, that might be something you've already picked up that he might be thinking about. This might motivate and act as a making every contact count and make it meaningful for him. How high is his cholesterol? What does high mean for him? What does that ratio mean? What would happen if we brought it down, and how we could do that? And also personalizing it. So when you've got that group of people, it's 20 Jamals. So it's not just 20 people, it's 20 people like you, Jamal. And this is the first aspect of a shared decision-making conversation. So following the 3-talk model from the BMJ that many of you will be familiar with, you've done the team talk in that golden minute and thinking about his risks, and you're starting to move now into the option talk of the different opportunities and things that he might be keen to try. So you gathered the information, now you're starting to think, and you've got those cues to build into the option and decision talk. But what are the options for him? Well, you might have tweaked the Q-risk 3. So this is a slightly different example. You'll see that the risk has more than halved there for Jamal, because he's had a look at actually if he was an ex-smoker, that's something that he can change. If his cholesterol dropped, that's something that he can change. If he lost some weight, that's something again that he can change. And what does he want to pursue and not pursue? Equally, this is quite complex. If you've not seen it before, you might get a bit bamboozled. So are you getting a completely blank look and you need to stop and actually say, I'm going to switch tack to something that's a bit more straightforward. Now, that could be a language barrier. That could be health literacy. There isn't anywhere to hide with personalised care and shared decision making. We've all had that patient who's sat in front of us and we've gone, I'm going to give you a statin. Yep. Okay. You have to take it every day. Yep. Okay. And then in 3 months' time, they come back for their review and you notice that actually they've not ordered it and not taken it, and you go, they didn't get it at all, did they? So we need to make sure that in that conversation, we are eliciting that understanding from our patients. Now, If English isn't their first language or they're from a marginalised group, are we assuming that that person with no medical training can see the link that we know because we've been trained on it, from cardiovascular events through to their heart health, through to the factors that affect it, through to atherosclerosis, through the factors that affect that, to lipids, to statins? Do they understand the consequences if they've not got a family history, or are they terrified if they have got a family history? So we need to help Jamal to join the dots to make an informed decision on the risks and the benefits, as much or as little detail as is needed. Now, if he's given you that blank look, actually, maybe it's just time early on to step away from that and to use a different tool. Some of you will be familiar with the Heart UK website. Compare this to that previous infographic. It basically says a very similar thing, but it's completely different and it's more pictorial. And he might actually just pick up and point at something and say, I want to try that. Would they like to know more? Do they want to read something? Do they want to watch something? Being aware that the young people are very digitally led these days, so they might prefer a video. Or again, if somebody's not able to read, they might prefer a video. You might have to be looking for things in different languages as well. So Heart UK, really helpful website to send. You can send specific links as well, and you can keep clicking in. You kind of go down that rabbit hole of, right, here's the basic information, here's slightly more, here's slightly more, here's the detail, and through. So there's a lot to signpost to. And it's like being an electrician. Part of what you do is having the skills to do it, and part of it is having the tools, and this is building your toolbox. So you've already seen and probably used some of those tools already. Here's another one that you might be familiar with, which is GP evidence. So it might give the same message in different ways depending on the needs of that person. So in this case, you're looking at GP evidence. You've got the smiley faces again there on the left, but what you've got is a bit more detail on the risk reduction and the numbers needed to treat. On the right-hand side there, you can see information about the harms. So people might quite often be coming to you concerned about muscle pain, for example. So there's a little bit more information. Again, if they've been a little bit worried and they've picked up on something as you've gone along, it's a good chance to explore it and actually look at the evidence in a way that they understand. But equally, it helps you have some other conversations. So if you've got someone who's come along and said, I want to start on everything, I want to do everything that I can do, and you're like, right, let's diet, let's stop smoking, let's exercise. What are people always worried about with the risk of statins? Muscle pain. What do you get when you exercise? Muscle pain. So actually starting both of those things at the same time maybe isn't the best thing to start together. Maybe let's do one and then the other, and let's explore which one you might find easiest. So the expectations again around follow-ups, blood tests to check liver function, thinking about their work, their reliance on public transport, for example, that might be a barrier for them. So it's thinking about all of these things as you're having that conversation. But I would just challenge you to think, when do you get your planning or education time to familiarise yourself, not just with the evidence, but with the resources that you'll use in practice and speak to a patient about? So that's really important to reflect upon and make sure you take that time, not just to think this is the evidence and this is what I'm going to say, but these are the tools in my toolbox. So you've done your team and option talk, you've been through the different choices, and it's then time to make a decision. And this is the bit again that's quite new to us. So we used to say you're going to do this, whereas actually now it's Jamal, you've got 5 options. What are we going to do? So you'll go back over the main points as a reminder briefly, and you can either decide now or later. If it's later, how is that going to happen? Are you going to ring him? Is he going to ring you? And equally, it might be the first time that Jamal's ever had a health coaching approach, and everyone's given him a choice and not just said, Jamal, you're going to do this. So he might want to speak to his family and friends. He might have a wife, children, parents that he wants to talk to. So making sure that he does that if he wishes to. Equally, he might want to talk it through with you, and he might want to know, doc, what do you think? Pharmacist, what do you think? Nurse, what do you think? So you can try something to see how it goes. His fate isn't sealed. If he's trying something today, he can try it. That's fine. He can review it. If he's not trying something today, then the door's open for him to come back. And it's also an opportunity to check safeguarding and control issues. Again, there is nowhere to hide with personalised care. If somebody is, being coerced or being controlled, it's just that opportunity to pick up on those cues and to actually think, do I need to do something different here? Because today it's the lipids, tomorrow it's the opioids. So it's just being very cautious. And it's not an either or, it's a yes and. So it's not a stop, we're doing one thing and we're only ever doing one thing. It's a part of a journey, as we talked about earlier. You might need to think about bespoke options as well. So you might need to think about bespoke dosing and build confidence in the patient in that medicine to have a later discussion on full and different treatment. And then another challenge back to you is when someone makes an informed decision that you think is unwise, what happens next? What do you do next for them? And what do you do professionally? So that chances of you hitting that quaff target, you feel they're slipping away because he wants to think about it for a week. And really, you'd probably rather that they were honest with you to choose the best options for them. Or he could just keep ordering the statins every month and not taking them, or he could come back in 3 months not having ordered them at all. Because when he does come back, the numbers won't lie. So his tests will tell you whether he's been taking it or not. But you want him to be honest with you if he hasn't, and if he needs some support with it and what that might be. So, of course, it's not just about the statin. You've picked up earlier, Jamal wants to improve his diet and stop smoking. You want to help him along on his way for those 8,759 hours. Again, there are lots of tools out there. Let's make sure we're sending people to the recommended tools, because otherwise they're going to go away and they're going to Dr. Google it and it's all going to go horribly wrong, because it's only a few clicks through to that dodgy disinformation. So make sure that you're giving them plenty of information that they can have a look at. And equally, you're not on your own. So your health and wellbeing coaches, your social prescribers, they're vital partners if you do any work around long-term conditions. Do you know who that person is in your primary care network or your practice? Do you know them? Do you know what they do? And do you know how to refer to them? If not, it's another challenge back to go and find out a bit more. Good news is Jamal chose to try the atorvastatin, but there are a lot of barriers in his way, as Rani's described. It's a bit like the 110-metre hurdles, and a lot of those things are practical things. They're not the things, clinical things that we would talk about, but they're the practical things, that forgetfulness, that physicality to be able to get in. So does he understand the system? Has he had medicines before? Can he afford them? Is cost a barrier? Do you know how to signpost somebody to information about free prescriptions? Do you know your community pharmacist who can help describe that to him and signpost him? How does it fit in with his routine at home? How will he remember to take it? What are the things that he does at times of day, every single day, day in, day out, that will help build into this routine? Does he know how to order more when they run out? And how will it be followed up? So you might be thinking, oh, electronic repeat dispensing, for example, might be really good for Jamal because this is the only medication that he takes. Equally, he might be taking 5 other things already. He's got type 2 diabetes. So how's it going to fit in with that? Will it fit in with that? And sharing materials back. So things like the websites, the apps, thinking about the language and literacy that we've talked about. Your community pharmacy, as I've said, is a huge help for all of these enablers, and they also do a follow-up service called the New Medicine Service, which will help you see how he's getting on with that statin in that early couple of weeks that Rani talked about. So that's a quick whiz through Jamal's experience today, but there are a lot of other circumstances that you might come into contact with. So secondary prevention, where somebody might have some knowledge, they might not want it again, but equally they might be, really struggling with that. The adverse effects, where people will come in and the most important thing is that statin issue. That might be a more technical conversation. Guidelines are available, but remember things like the other changes we've talked about. Have they started or stopped exercises? Could we trial a bespoke dose to still get some benefit, or look at the alternatives from a statin? Switches, really, really easy. How many people have we still got on simvastatin? How many people are we still underdosing? That's a really easy conversation to have, where someone's not getting full benefit and we could actually give them a lower dose with a greater effect. Genetic testing, that's just something to keep an eye on. Horizon scanning, so we're more familiar with familial hypercholesterolemia, testing on the NHS, but actually in future we'll be able to test for statins as well, and the metabolism of those, the likelihood of adverse effects. It may be available privately with a health focus, alongside other things people might start asking you about lipid metabolism, for example. But horizon scanning, there's a lot more coming to that, and I've put a link in the end if you want to have a read. The missed doses, that mismatch, again, the numbers don't lie. When somebody gets a test, that's telling you whether they're taking it and how well it's working or not. So it's owning up to those missed doses. If they've been told off before by your predecessor, they're going to be terrified. So it's your chance to be curious and to be honest and have an open conversation. And then lastly is just about deprescribing. So where you're changing therapy or in palliative care situations, and adherence to preventative medicines is no longer relevant. So I'll just skip to this last slide just to think about putting it into practice. So we've talked through quite a lot today. Really, it's gathering your evidence. Evidence and resources are not the same. Patients are not going to thank you for 200 plus pages of nice guidance and papers. Your professional body will for your CPD. Are you comfortable that in this same position, you would choose the statin? Can you honestly say that to a patient? Your enablers, we've talked about there, the people who are on your team and on your side to help you. You don't have to do it all. Moving on to other conditions, so getting comfortable with it and then thinking, okay, I'm good at this, hypertension. So can I just ask people on their virtual hand where it says raise, can you put your virtual hand up if you're starting out with this or you're learning a bit more? It's your first time doing it or you're just learning a bit more today, and you're feeling a little bit daunted and a little bit nervous. Who's feeling a bit daunted and a bit nervous? I've been through a lot of that, and Rani's been through a lot of that, and there's a lot of pressure to get it right, and there's a few hands starting to come up. You're going to have to address the fears with your knowledge and use your feedback to gain competence. Have a go, be prepared to learn and be prepared to build it. But you know what? Every clinician that I have spoken to absolutely loves doing statin conversations. I've really enjoyed them when I did it. It was one of my favourite things to do in general practice. And I know speaking to my other colleagues that they feel the same. So I hope that you do too. So I'm going to finish there and just ask you very quickly for the last minute to go back to your Slido to think about what your next steps might be. Before I do, I'd just like to say a quick thank you to Jennifer, to Neve, to Laura, and to my anonymous patient who shared their experiences. And when you get the slides, all of the links and the resources and references that I've talked about are in there. So we'll just go back to the Slido to finish off, to think about what's your next step, and that will come up on the screen so that you can see everybody's. It is completely anonymous.
Thank you, Helena. That another excellent talk. Just whilst the Slido comes through, there is one question in the chat. What role do you think community pharmacy can support with this?
Oh, I think maybe I went on to cover that a little bit. So talking to them about some of the barriers. So cost is a big one, being able to take their medication if they need to make reasonable adjustments. So for example, somebody who needs a large label because they're partially sighted, reasonable adjustments are hugely helpful, and the new medicine service to see how people are getting on so they can have the conversation on that day. They can do a follow-up a week later to see how they're getting on with it, and if there are any barriers that they need, which with that patient's consent they can then feed back to you if that's needed. But sometimes it's just that reassurance and that listening ear and someone to back you up.
If I may, Jane, I back Helen's answer. I think community pharmacy are probably the team that the patients, or when they become people later on and continue to be looked after by them, they're going to be the most visited healthcare professional. And there will be plenty of opportunities to listen to patients of any concerns, and they can tailor whatever, whether it's information with the practicalities, as Helena said. So I think they're huge. Actually, they play a major role in supporting the patient longer term.
Also, Helena, also there's another question coming. Also, what role can community pharmacists play in community heart health checks outreach?
Oh, wow. That's again such an area that they're coming into. So they can already do the hypertension case finding. In some areas, there will be local services as well. And I have no doubt that this will develop over time into lipids. I know in North Cumbria in years gone by, we did lipids in community pharmacy as well. So you were having those conversations, and with independent prescribing coming, there is huge potential for actually moving some of that initiation into community pharmacy.
It does sound like a very exciting time, actually, and some real opportunities to improve preventative medicines. One more question, and then we'll finish. Is time an issue that impacts on giving personalised care?
Yes, hugely. I think it depends on the look of the draw as to where you fall in. So if you're a GP who has a 10-minute consultation with someone, it's really hard. If you are a long-term conditions person in primary care who has maybe 20 minutes, or if you're really lucky, half an hour. But remember, it's not just a one-off event. So if you can't do it all in that time, you can make the decision or send the information to make the decision later and follow that up perhaps with a 5-minute phone call.
Okay, thank you. We're bang on 1 o'clock. I'd like to thank you both for what has been an absolutely excellent session. I'm sure we've all got a lot out of it. I'd be very surprised if there wasn't if everybody wasn't going away with at least one learning point, and probably a long page of them. So thank you very much indeed. The session's been recorded and will be circulated, as will the slides. And if we can just have the last slide up, please, Jess. The evaluations are extremely important, as I said at the beginning, so please take a few minutes to complete those. Otherwise, thank you, and we'll let you go, get back to your clinics or your lunch or whatever. Thank you very much for coming, everybody. Bye-bye.
Thank you.